Well, good afternoon, good morning, good evening, and welcome to another first for the World Society of Pediatric Ophthalmology and Strabismus. You're joining us to watch our first virtual Strabismus wet lab. And I'm just going to share my screen now so I can introduce my talented colleagues. First of all, David Granite needs no introduction to anybody who's watched the World Society webinars over the last 9 months. David is the Vice Chair, Department of Ophthalmology, UC San Diego in the Shiley Eye Center, and is one of the founding members of the World Society. I'm delighted to be joined by Yining Stu. Yining is a Director of Pediatric Ophthalmology and Adult Strabismus at the Queen's University, Kingston, Ontario. She's Chair of the Continuing Education Committee of the Canadian Orthoptic Council and has been an instructor on the AAO Strabismus Skills Transfer course. She's also been instrumental in developing a tremendous new model for simulated strabismus surgery. Ramesh Kakanaya requires no introduction to people who've been watching these webinars. He has been absolute tour de force over the last 12 months of the pandemic and helping his WSPOS colleagues develop an amazing array of educational webinars. I'm delighted to be joined by Ramesh this afternoon. Rita Gama. Rita hails from Lisbon in Portugal, is a talented strabismus surgeon and educator and has been an instrumental part of today's webinar. Rita, welcome. And finally, I'm a consultant ophthalmologist in Cheltenham in the United Kingdom. I'm the chair of the Surgical Skills Faculty of the Royal College of Ophthalmologists. And if you're wondering why there's a picture of me golfing and surfing, it's just in case Ken Wright's watching because he doesn't think you can do both. So, a couple of housekeeping questions before we move on to the webinar proper. As always, WSPOS wants this to be as interactive a session as possible. So you'll be joining us from Facebook and YouTube. You can type your question in the comments section. David and Ramesh will be collating those. We'll try and answer as many of these questions as we possibly can. Also, don't forget Mentimeter questions. If you have downloaded the Mentimeter app or go to menti.com, this is the passcode. You can use this QR code and there'll be questions being pinged to you throughout the webinar. And again, we really want this to be as interactive as possible. So if you have any questions about how we conducted the webinar, the model eyes, anything that comes to mind, please feel free to ping us these questions. So, how did we get where we are today? Well, first of all, the World Society has an amazing track record in innovation and delivering strabismus surgery workshops. I've had the honor and privilege of taking part in the 3 World Congress workshops, as have many of the members of the panel, in Milan, Barcelona, and Hyderabad. And as you can see from these pictures here, they've got Jonathan Holmes on the left here, with his high-powered loops on, and you can hardly see the model eye because of people crowding around him. He was doing a superior oblique tuck here at the minute. And here we've got Lionel Kowal, we've got Maro Goldsmith, and it's almost like a human pyramid over him here as people are peering over and watching how to use a different selection of model eyes to teach strabismus surgery. And these were one of the most sought after aspects of the World Congress. In fact, in Hyderabad, there was queues outside the door as people were trying to get in who hadn't had the opportunity to book to get into these wet lab sessions. So I thought it would be interesting to play this clip of the Hyderabad workshop, just to get a feel for the buzz and the excitement that was going on in the room. And also to hear, Ed Wilson, talking about the workshop with David.
Here at the Third World Congress of Pediatric Ophthalmology and Strabismus in Barcelona, Spain, with Professor Ed Wilson, who just walked out of the Strabismus simulation workshop. You've done this before. How was it this year?
It was fabulous. I mean, having a hands-on demonstration, it's amazing. And we had students that were beginners, we had students that were experts, and they each, I think, got their questions answered in a way that they could see, not just hear, how different people do it. I thought it was great. The model has been improved since Milan. It keeps getting better. It keeps getting more realistic. I loved it.
Do you think there's a role for using this type of model in any teaching session, whether it's in the United States, internationally, everywhere?
I feel a little guilty that we don't use it more. We really should. This allows our surgeons to get real practice so that we can make these basic points before we're in the operating room using anesthesia and a patient.
At the beginning of the session, you said our goal is to make sure that we have competent surgeons. Do you think this helps achieve that goal?
I really do. This will make them competent faster. And they can take the model home and practice and really be at a certain level before they enter the operating room. I think that's essential.
While I was watching everyone around.
So I think Ed made so many salient points there. The fact that we're trying to get people to become competent before they enter the operating room. The fact that you can use Model Eyes at home to practice. Sustained, deliberate practice is key. And it's great having these lovely workshops, but if it's a one-off thing, that's not good enough. It needs to be sustained, deliberate practice. And really our goal is to try and facilitate that. But before getting on to how we've developed the webinar today, I'd like to just highlight two papers which have been published in the last 12 months by my very good friend and colleague, Will Dean, who is a superstar in the field of simulated ocular surgery. And this is the key principles of simulation have been enshrined in these two randomized controlled trials of small incision cataract surgery, the Olympics trial and the GLASS trial. Olympics trial published in JAMA Ophthalmology and the GLASS trial in the BJO. These are the world's first randomized controlled trials of simulated versus conventional surgery. And this is a picture of Will in Nairobi because they're based in 6 Southern African countries. And as well as using Model Eyes, the premise was to use basic materials, apples, rubber, silicon, foam, easily accessible, cheap materials to start your simulation journey before moving on to these sophisticated Model Eyes. Because one of the things that we have to overcome when introducing simulation is to prove that it works, prove that it's effective. So these are the results of the Olympics trial. So at baseline here, the 25 trainees who started using the Model Eyes to do a small incision cataract surgery procedure. And they were measured, their competence was measured on an Oscar, a special scoring matrix. And you can see at baseline, they were all pretty terrible, 10 or 12 points out of 40. But after 2 weeks of simulation, the simulation group were incredibly competent. And following that up, looking at their confidence scores, that also doubled. But over a year, not only had these people done many times more procedures, the complication rate was reduced by 72%. And when you look at the randomized controlled trial for glaucoma surgery, their competence rose 3-fold after a 1-week course. And their confidence also increased on a Likert scale by a factor of 3. So we know that simulation works. These RCTs show that it works. So how can we transfer this to strabismus? WSPOS has really championed the idea that expertise resides all around the world. And all the webinars that have run over the last 10 months have emphasized that. So how do we tap in to that reservoir of talent? And how do we get that talent, the talented teachers, to trainees all around the world? And that's what this webinar is about today. So the first thing that we thought we would do is try and devise a simple model that anybody in the world can have access to. The model eyes are great, but your journey can start on the simple model eye. And the next video just shows how we asked our trainees who took part in the webinar to make the model eye. We went onto the simulation gallery, they clicked on that, and there's the videos are there free to access, and they watched these and they made their model eyes.
Today I will show you how to make a simple and cheap model eye for practicing many different aspects of strabismus surgery. All you'll need to make this model is 1mm thickness modelling foam, ping pong ball cut in half, some tape, and matchsticks or cotton buds. If you want to practice making scleral passes of the correct depth, oven hardening modelling clay can also be used, but it's not essential. To practice your scleral passes and muscle surgery, you'll also need a pair of suture ties, Westcott scissors, and Moorfields and St. Martin's forceps. The ideal suture to use is a 6/0 Vicryl on an 8mm spatulated needle. To make your model eye, roll out your modelling clay and cut into a strip. Cut your 1mm foam into a strip, roughly 2 by 13 centimetres, with your limbus drawn on. Cover the ball with the modelling clay and then layer over the foam. Stick down with the tape, trying to keep the foam as taut as possible. Now you can practice scleral sutures. Holding the needle 1/3 down the body and with the tip horizontal, press downwards to engage the sclera. Too superficial and you'll only engage conjunctiva and tenons, and in the model eye the foam will just tear through. Keep pushing down as you rotate your wrist and tunnel through before remounting the needle, ready for your next pass. If you hold the needle too far down at the swage, you'll have poor control of the needle pass. If you angle the needle tip down, you risk perforating the sclera and damaging the retina. To check if you've made any suture passes too deep, check the modelling clay. Any scleral perforations will be obvious. You can also practice reverse mounting your needle and trying reverse needle passes. To make things slightly more tricky and more lifelike, use your leftover modelling clay to make the shape of a nose or a brow to get in the way.
The second thing,
finally, to make a model eye that you can practice muscle surgery on, make parallel cuts in your foam perpendicular to the limbus and about 5mm back. If you cut short lengths of the matchsticks and slip them under the muscle, this lifts the muscle off the eye as a squint hook would, so you can practice independently. Further videos are available for how to practice.
So they watched that video, and then they also watched this video of one way of doing a fixed hangback recession. And as you'll see from the edited highlights from each workshop, all of the trainers do this slightly differently, but they were still able to convey those messages during the workshops. But the trainees were asked, but not all of them did, but most of them did watch this little video. Again, made by Rebecca Jones, who's a second-year trainee with me in Cheltenham.
With a double arm 6/0 Vicryl, take 2 passes through the middle third of the rectus muscle, just 1mm away from the insertion. Then take a partial thickness bite through the edge of the muscle, supinating your wrist to regrasp the needle in the right orientation for the next pass. Pick up the suture close to the muscle edge and take another full thickness bite. Wrap the suture twice around the needle and pull it through. This creates a locking suture on the edge of the muscle.
So that video goes on for another 2 minutes, and it just explains exactly how we do a whole recession. But what I'd like to do now is hand over to Yi Ning, who's going to talk to us about how we went about organizing the live webinar, which we conducted last Sunday, and the research project we have running alongside. Yi Ning.
Thank you, John. I'll just share my screen. Bear with me. Okay, so briefly, I'm going to go through how did we set up the classroom. And the setup for the instructors and the 10 participants was the same. So I'll just walk you through that. John's nicely shown you what the model eye we expected everyone to use was made of, and you can see that arrow there showing that. Everyone was asked to have simple surgical instruments and the 6/0 Vicryl spatulated suture, spatulated needle. and then a cell phone to allow the participants and the instructors to record in Zoom what was happening with the model eyes showing just their hands, and you can see that on the screen. A cell phone holder to mount the cell phone to do that, as well as a light source, which just helps make things sharper and clearer for teaching. And then some of us, all the instructors and some of the participants also had a computer with a second camera so you could see the arm position. So it's not just a zoomed up view. We need the Zoom connection. And most importantly, enthusiasm. I think Rita wins for that. A WSPOS e-blast was sent out to advertise for today's webinar, as well as being willing to participate in the live session that happened last Sunday on the 21st. And we had a great interest. I wish we could have done sessions for everyone, but we ended up taking 10 participants who were novice learners, really with no prior strabismus experience. John's already gone through the videos that we asked them to watch prior to the session, but to not practice them. So really to see what was their baseline and how did they improve over the hour. And this is a montage of the 5 of us on this call, the 5 instructors from all around the world with our slightly different setups, but really easy for us to set up. And we started the session on the 21st with a brief introduction, explaining what our goals were for the session, all in one group. And the teaching aims were really basic. We wanted to explain how do you hold the instruments, correctly load the suture needle, how to tie a square knot, importantly, how to perform a safe and secure scleral pass, and then finally, securing the rectus muscle with a 6-0 suture, simulating a rectus muscle recession, all using that simple model. So then we spent most of the day on the 21st in breakout rooms. Here's a snapshot from my breakout room, and each breakout room had 1 instructor and 2 participants. And that breakout room went on for about an hour. And this is my last slide. It was a great session. I think instructors and participants equally enjoyed it. And we're going to show you some feedback from that. John described that we're planning on doing some research. And, our goal really is how can we make this better? How can we reach everyone so that we're equalizing exposure and experiences with hands-on training? So we're looking at participants' comfort before and after with a research study with survey data. We're also looking at feedback and what are the teaching points? What are the common threads and how does that compare to the live teaching? And we have exciting research planned for our next WSPOS webinar, exploring these ideas. And again, with the goal to connect our instructors worldwide with trainees such as you listening to this call, and ultimately to make strabismus surgery better for all of our kids and adult patients around the world. So I'm going to stop sharing my slides now. And what we're going to do now is we're going to show videos from the workshop with edited clips. So John, you can pull that up. And I believe we're going to stop in between each session, each breakout room, if anyone has questions for each of the instructors. And for those of you on the call today that may have already watched the how to make a model eye, feel free to practice as we're going along. Maybe you'll get some tips. Or maybe a question will come up. Once you actually try, questions come up rather than just watching. And no worries if you weren't able or were not aware of setting up the model. All of these videos are available on the Simulated Ocular website, Ocular Surgery website, as well as the YouTube sites with all the WSPOS videos. So I'm going to pass the baton back to John.
John, while you're getting the videos set up, let me just let you know where people are watching from. Besides the United States, Canada, Portugal, and India, we have the UK, Spain, Germany, Switzerland, Mexico, Ukraine, Tanzania, Latvia, Philippines, all my friends in the Philippines, hi, Russia, West Java, Indonesia, Pakistan, Brazil, Argentina, Saudi Arabia, Lebanon, Israel, Singapore, Hong Kong, Australia, Colombia, and a couple other countries in Europe, John, that are near you on the same time frame. Include France and Sweden, Norway, Greece, Georgia, Malaysia, Ecuador, Myanmar, and it goes on and on. John, you're muted, so we don't hear you right now.
Hopefully you can hear me now.
Yes.
Good. So this is David's classroom. I think you were first up. You are indeed. Here we go.
To the foam or the sclera here, indent it a little bit. That will create your surgical plane. Don't ever point down. If you point down, no one will let you operate. And then, so you indent a little bit. The sclera is distensible. And then you advance forward. Remember, the needle's curved.
And then come up.
And then slowly follow that curve out. You see the point? And if you've done it right, hold up for a second. Don't do it. Nope, don't grab it. If you've done it right, that the passage should allow you to see the thickness of the needle as it goes to the sclera. So you can see the foam in this case should be slightly elevated where the needle goes through it, because then you know you haven't been too deep.
Okay.
Everything about this is one, to protect the patient, and two, to anchor the suture strong enough that you don't have to worry about it ripping out. Now, generally, we handle the needle as little as possible because we want to make sure it's as sharp as possible when it goes through the sclera. If while you're showing a muscle, you handle the needle too much, you can damage it. So now, of course, we started right in the sclera. You want to advance the needle to about the swage or the hub, depending on where you are in the world. We call it differently. And then you'll have enough to pull it out by grabbing the tip. And remember, the needle is curved, so don't pull it out straight. If it's curved and you pull it out straight, you'll rip tissue. If you follow the curve out on a curve, then it'll come out smoothly. So as you pull this out, you want to be turning your hands or your fingers and roll it. Very nice. So try not to grab it on the hub. Whenever you do, the needle can rotate. Now wait, this is where it matters that you lock.
Okay.
Do you see your loop? Yes, exactly. Okay. And sometimes some people start to pull it and then lock it, but you want to make sure that you're through that loop.
Okay, so
and don't pull it straight. The needle's curved. So you want to roll the needle out.
Okay. So
instead of pulling it straight. Go ahead. Now as it tightens, that loop will tighten.
Okay, so
go slow. Go ahead, pull it. Do you see it's all you have is a loop there?
Yes.
Right?
Yes.
Now you want to be through that loop to make it a lock.
Should I do that?
Yes.
Okay.
And the less you handle the needle, the better, because that needle has to go through the sclera. So at this point, you want to be handling the suture. Can you tell that it's locking? Were you able to tell that it was locking?
I think it's
that
locking.
The suture came through the loop rather than next to the loop.
Yes, I think yes.
Perfect. That's what you want. That's what you want to accomplish. And you want to try and handle the needle less, because when we cut that muscle off the globe and we have to sew back onto the sclera, that needle has to go through sclera. And you want a needle that doesn't have nicks on it and that hasn't been flattened out or changed by handling it too much. So when you're pulling it through, grab the suture behind it rather than grabbing the needle, so you don't have to worry about altering the sharpness or the contour of the needle for when it goes to the sclera. Does that make sense?
Yes.
Great. So is it helpful to watch while we're talking to the other person? Is that a good teaching? Yeah, I think it takes you out of the muscle task.
Definitely.
And you get to just look, right? So now
I always feel like the more times I hear someone say something, the more it becomes part of my own narrative in my head.
Sure.
Perfect. Okay, so now I've got one long and one short, and if I pull them like that, I can see that.
Correct. And you see what happens? The muscle comes up. And when you see how your muscles now slid back a little bit?
Yes.
There's a gap. Pull it up. Pull it. See, it comes together.
Yes.
When you sew it and you tie it, you want it to come together. So when you throw your knot, if there's a gap, then you increased the recession. The muscle fell back further. So this throw is important, right?
So this is the one we have to pull tight.
Yes. And you see, not so tight that you accordion and pull together the sclera, but tight that the muscle comes together. See, it comes together and it holds. And now you throw a square knot down the opposite direction from what you just threw. Yeah, you threw forehand. That was backhand. Perfect. And then lay it down. Good. And it should stay. Good. And then one more forehand so that you have a square knot on top of that first double throw. Now, my residents at this point usually stop and look at and admire their own work. Like, ta-da, look how good I did. So, and then depending upon how long your consultant ophthalmologist wants that suture to be, is how long you cut it. And in surgery, there's an old question that we're supposed to ask the attending surgeon: would you like your sutures cut too long or too short today? And no matter what you do, the surgeon's going to tell you they were too long or too short. And that's normal. Don't worry about that. In general, you can always cut a suture shorter, but you can't make it longer. So residents and trainees tend to leave it longer, knowing that. And I can't argue with that.
So just going to go on to the feedback from David's group.
Seems South Africans want to have our say. I also feel incredibly grateful to have been able to participate in this. I'm a little further behind Hetty in the road. I am not yet a resident. I'm in the medical officer program. Our program runs similarly to the UK. I have been a medical officer for a few years and I'm waiting for a resident post. And I haven't had the opportunity to operate at all. I think what I loved about this is that I could make my own model. And I know there's talk of maybe putting together something we can buy on Amazon, but buying on Amazon and shipping to South Africa is really difficult. And I value the fact that I didn't have to import anything. I went to a number of shops to source all the components, but that I could make the model and participate all the way down in South Africa. I think that was fantastic. I also loved the individualized nature of the teaching, and just being taught by an expert is such an honor and a privilege. So thanks. I thought it was fantastic. And I was saying in our session, like, when someone teaches me and explains to me what I'm meant to be doing, I try and let that become part of the narrative in my head. And hopefully I'm going to hear your voice, David, as I'm loading needles and not pointing the needle at the globe. Thank you.
Catherine, that's so kind of you. Thank you for that feedback. And I bet all of the instructors have heard from their residents that the residents hear their voices in their head, because we tend to repeat ourselves. It's the nature of repetition is the soul of teaching, and we tend to repeat ourselves over and over. So I'm sure that I hope that happened it wasn't just us.
Yeah. Also, just lastly, with our exchange rate, the fact that we were able to access this for free is a huge privilege. At the moment, we are paying almost 16 Rand for a US dollar. And so the fact that we could join was a huge privilege. Thanks.
Okay, so it was a very nice experience. So I think the videos helped us a lot to prepare. So in the end, I think all of us managed to understand the procedure, because personally I had no experience of strabismus surgery at all, and many of the rest of the participants, as I see. So I think it helped us to move one step forward maybe and just familiarize with the procedure. So it was fun. So David was fantastic. So I think overall it was a very, very nice experience.
Tell everybody where you are.
Sorry. So I'm in Greece. So I'm a resident in Thessaloniki.
Look how many new friends everyone's making from around the world.
Mm-hmm.
Yeah, John, it was incredible, right? An instructor from the USA and 2 students, one from South Africa and one from Greece, on the via the internet, talking about strabismus surgery and teaching strabismus surgery. It was really moving for me, frankly, to be a part of that experience. And there's so much to unpack for what you just saw. I think as an instructor, I have to learn how to get better using this modality, and how to talk to people. But I think the idea that this little ping pong ball model is such a good model and so close to what a real eye feels like. Having used it myself, having taught with it now, that I would feel comfortable, so much more comfortable having either of those 2 fabulous trainees come to the operating room with me, knowing that they understood not to point the needle at the globe, and to what it means also to listen to an instructor. If you saw at one point I said stop, I think all of us as attending physicians know that when we say stop, we want someone to stop. So there was this confidence that I developed in them, and that, as well as what they developed in their own skill set in preparation for going to the operating room. And that was separate from us proving whether or not that this could be done. So we had, could we do it? That got lost. It became, to me, it was just sort of obvious we could do it while we were in the middle of doing it. And you heard what the trainees, what they said is that you got lost. It was no longer a model, right? It was an eye. And suddenly you're operating. And that was pretty amazing. I wish I'd worn scrubs like Yining had to make it feel really like an OR, but it was really a great positive experience. And the other part that you'll see as we go along is the amount of repetition amongst instructors from different parts of the world who we didn't discuss this ahead of time. We operate in our own operating rooms. We trained at different places, but there are some basic key parts of strabismus surgery that we all just went right to. So it was a great experience.
David, I had one question for you. When you set up this, for the first time, probably you're teaching someone who are not in San Diego. They are sitting somewhere else. There is a cultural difference. There is an infrastructure difference. At WSPOS, we are trying to reduce that difference between different countries. I just had one question. What was your experience, the first experience of, the technology, both making the model as well as showing what you are doing? Can you just share your first experience?
I'm in my home office. I was looking for the equipment, and here, I don't know if you'll be able to see it, but it's like a simple ring light. This is a few dollars here in the U.S. And I have, yikes! I think I just dropped it. I have blue construction paper, a ping pong ball, and some material that we put on top of it. With John brilliant to use a cotton tip applicator or a Q-tip to create this and cut. It's inexpensive. It was sort of fun to make. I was dubious that the 1 millimeter foam would feel so much like sclera or enough like sclera. Perhaps maybe we need a 0.5 millimeter foam for immediately behind the muscle to really make all of us nervous. It was inexpensive. It was somewhat fun to do and not difficult to find here. And from I was a little bit worried that we might have people whose English was a second language. As someone from the United States, I'm a typical American. I speak one language, and everybody around the world is much smarter than I am and speaks multiple languages. But Ephthymia from Greece the first thing I did was make sure I could say her name correctly, because I think that it's incumbent upon us to try and work to understand other cultures, and getting a name right is the beginning of that. But in the end, there's a patient on a table with an eye and a muscle that needs to be moved or cut. And that boils down to there is no cultural difference, right? I mean, we're cutting a muscle and moving it. Whether you use loops or a microscope, that might make a little bit of a difference. But this is where what we all have in common is patients that need our help. And this is one of those ways that we all absolutely come together at the same point, which is how can we enhance our care of the patient? And by preparing before you go to the operating room. And in much of the world, you have people who they're general ophthalmologists, and they're the only ones who know how to do a muscle in the area. So this kind of training allows us to multiply our capability of helping take care of people.
Right. Thanks, Dave.
Okay.
We'll carry on, Rita. We'll carry on, because we're going to your classroom in a minute.
Okay. What are the concepts that you think are more important to teach at this level, basic level?
You know, what I thought was going to be was how to pass the needle by depressing the space and going forward rather than pointing down at it. I thought I would be emphasizing that. But what I found out was that working with a trainee who has less experience, just to understand the interaction between the attending physician and the trainee in terms of you're plugging your hands into their brain, sort of, or their hands are going to our brain, and then you're going to disconnect your brain and let them control it. But working with them to understand that they are demonstrating in the operating room they're safe, and that they understand the things that we're talking about and our description, and that to listen and not just go ahead. Even in the model eye, it made me nervous when they would just plow ahead quickly. I'm like, wait, slow down, because in the operating room that would be a reason for me to go pause, and I go, okay, now move your hands away from the eye, slow, and then we talk. So we were able to do that, and I think having someone get that experience and understand how to interact with their attending physician and accept the concepts, that became part of what I was trying to teach also, and I didn't know that would happen. And then in such a short period of time, and to see the confidence level of how just to load a needle. I mean, I forgot, we got to talk about loading a needle, right? I mean, and where to load the needle. And we all talked about that in our sessions, literally. So that we forget sometimes, as people who've been doing this for a long time, the very, very basic parts of what we have to do. I do that with my residents in person, but here we were in 45 minutes or so, taking them from loading the needle to listening to an instructor and assessing a muscle. That's amazing to me. I mean, it's just amazing that you can take someone that far.
Right, Ron. Rita, we're going to move on to your classroom next with Jason and Jeffrey from Hong Kong. So I'm just going to screen share again.
Wants to start. We can start making a perpendicular to the limbus.
Okay. So it's just a pass through the limbus.
Yes.
Through the limbus.
So Jason, you're doing it next to the muscle, no? I can see.
So do I hold the eye?
Yeah, you can hold it. Usually we hold it with the forceps, but in the eye model,
yeah, because I'm just scared the eye model will move.
Very good. Very good. I'm looking at Jeffrey now. Yes, and you got it. Now you should check. Yeah. Isn't it too deep? We should check now the clay, if you've passed it or not. No, if you touched it. You can remove the foam and check. See if the clay. Oh, very good, Jeffrey.
Yeah,
Done.
so
Well done, well done.
so
Okay.
that to full thickness, and then I go partial.
Yeah.
Okay, like 1 millimeter away from the edge.
No. The partial is exactly where you've stopped until the edge of the muscle.
Oh, okay. So
I'll do it. Look at me.
okay.
You'll be here. My suture is there, but pretend it's here. You do this. You have to do this.
Oh, okay.
Okay?
Okay,
In the
okay.
middle of the body of the muscle, not the full thickness.
Okay.
Yes. Yes. And then you go back.
Yeah.
Just pull it, and then you go back 1 millimeter from the place where you are or the suture is,
Mm-hmm.
and do a full thickness. Go on. Full thickness. Yes. This is a locking bite. Yes. Your movement of the wrist is really good. Okay. And then you pull it. Don't pull it until the end. Pull it. Yes. Oh, yes. And now, no, not until the end.
Oh, not need to the end. Oh, okay. There.
No, because now, see that loop? You have to pass the, yes.
Oh,
You have to pass the suture inside that.
Oh, okay. So
you can use the needle holder. Yes.
Like there, like this?
Yes, exactly in the middle. So you're making a knot, in the end, that's the purpose. So you can fix it. Okay.
I'm not sure if mine is correct, because do you see mine? So basically both of my suture ends are on one end. Am I missing a throw on this side?
I cannot see.
Is it the both?
How did it happen? Okay, let's do it again.
Yeah,
you say something.
Yeah, I didn't watch the video at all beforehand, so
okay.
That's why I got a bit confused with
but you're doing well, Jeffrey, pulling down the sutures away from the cornea, and now you have to cut between the suture that you have made and the cornea.
Yeah. So
with the scissors, you know, the tip of the scissors pointing upwards. Very good. Yes.
Okay.
Jeffrey, we have to stop now. I wanted you to finish. So tell me, can you show me your face and tell me how you felt about your first strabismus surgery? Successful strabismus surgery.
Yeah, I mean, a few hiccups along the way, but overall, I think it was a really good learning experience. Yeah, maybe in hindsight, if I watched the videos beforehand, I would have known the steps a bit better. But I think the hands-on experience was really good.
Yeah, it's the first time. So when I watched the video, I think it appears less difficult. So when you do it hands-on, it's totally different experience. So yeah, I think it's great to have this opportunity to like get introduced into strabismus surgery. Yeah.
I definitely learned a lot, and it gave me a much better understanding of what strabismus surgery is. I could feel myself improving along the way.
Yes, me too. I also felt it.
So, Rita, that looked like a lot of fun. I'm going to pass it over to Ramesh, who was going to ask you some questions about your Hong Kong team.
But I would like to make a comment before that. It was a wonderful experience. We had lots of fun. And I would like to make some comments. These trainees, for my surprise, they had very high skills, and the scleropass was really easy for them. But they had to find it difficult to make the recession, but they managed pretty well. I would like to point out that Jeffrey was not prepared for this session because he didn't see the videos, and that was a mistake and made him make a mistake. So he took it for granted. And I would like to tell you a small story that happened to me when I started my surgical training. I started with general surgery. And one of the experts was telling me that at that time, was a long time ago, there had been an article published relating the risk factors to have complications on a cholecystectomy. And the risk factors were to have a simple surgery, predictable simple surgery, inexperienced surgeon, and a surgeon with a hurry. So these three factors show that the attitude of the surgeon might be the first step for you to have a complication. And this can happen to trainees as well as very experienced surgeons. So I think we can learn from this example that Jeffrey has shown this, that surgical skills that we're practicing are not only based on hand movements, but also the attitude you're bringing to the OR. As we can see, he's a very skilled surgeon. So he moved to the second eye model and done it perfectly without my supervision, because I was helping Jason cutting the muscle and retaching. But his hand skills were not good enough to make the first eye look good. It didn't save the mistake that he has made. So I would like to state that 4 basic principles that like we're having on this course, you should never underestimate your surgery. You should study your patients, study your surgery, and be humble. Pay attention to all the small details that are happening, and asking yourself, is my scleral path deep enough? Is this not tied perfectly? Because mistakes can happen, and even some events that are not expected can happen. But the best way to prevent this kind of mistakes is being prepared to learn from them. And even though you think it's a simple surgery or something that you can do it perfectly well. I think it was a wonderful example.
Absolutely. Ramesh.
Thank you, Rita. I think it was very good, teaching itself, whatever that the way the procedure was passed in a different way, that itself is a great teaching as a training as well as mentor. So I just wanted to ask one question. It's you have a lot of experience in teaching face-to-face simulated surgery, even in the workshops or in your institute. I just wanted your experience compared to the face-to-face, how this was different, the virtual workshop, how different it was. What are your kind of concerns, what you had, and how did you overcome? Because many of the mentors might be watching this webinar. They would want to know what is your experience on that. Can you share some of the tips for the mentors as well as mentees? Thank you.
Thank you for the question. It's more difficult because we are used to a face-to-face, and sometimes you see some mistake and you want to really to correct the mistake, and it's not possible to do it online. I think if you being patient and trying to express in words what you would do in with your hands gestures, that's the way to do it. And understanding that we're talking with people that are on the other side of the world, which was my case, and these trainees. And even though we're so apart, our language is similar. And I was really surprised that in 1 hour they could make it so well and correct everything they were doing. So what are the tips? Be patient. Use your cell phone pretty well, and pay attention to all the details. What happened to Jeffrey, I was not aware that he was doing that, you know, and if he was in my OR, I would have seen it immediately and corrected. So there's a gap here, but well, in time, I think we'll improve that.
Rita, your point about being prepared, you know, maybe is the most important thing we'll talk about today. I think for a resident trainee to come to the operating room unprepared is not okay. And so much of strabismus surgery takes place outside of the operating room in your head. And your behavior. Your tip and the point you make about that is so crucial, and I thank you for it. You are the most patient teacher, I think, and I would love to have been your student, learning from you, because you do it with such a smile. But what I wanted to ask you was the difference between teaching someone in the operating room and teaching someone out of the operating simulation like this, the level of stress you feel with a patient there versus when you have a model there, and what it's like to be patient as an instructor when you don't have the stress of an actual live human being who's counting on you.
Yeah, well, of course, the eye model makes it that easy, you know, and even to wrap it up and see what's going on behind, that makes it so easy. But you cannot replace one thing by the other. We're training basic skills on hand skills, and human contact and having a responsibility of a patient is completely different. But I believe these first steps are crucial for them to understand. Both of them said, I have to watch the videos again now that I've started. And we know surgical skills are a learning process. You know, you don't have to watch the video only once. You do it over and over, and then you repeat it, and you do it on, you try it on your eye model, and you have to see it again, because there are always some tips that, no, you missed that. So it's a learning process along the way, but through all your life, your professional life.
Just brilliant.
Right. So we're going to move
John,
on
back to you.
Over to Yining's classroom, and it's highlighted in the videos I've created. If you watch, especially Tracy mimicking Yining and some of the movements she makes during the teaching, I thought it was absolutely superb. So I'm just going to share my screen again, and we'll click on that video. Here we go.
Important is you don't want to be grabbing. I'll just demonstrate the incorrect way. You don't want to be grabbing the needle right up where the suture joins the needle. That part of the needle is round, and you'll get wobble when you're placing your scleral pass. So it's very important that you grab it on the flat part of the needle, as I've shown here. Okay, so that's the first thing. As you can see, I'm using the curved needle driver. And so when you're loading a curved needle driver, my needle is pointing this way, and you want the curve to be away from the direction of the needle. And what we'll practice this morning for me, is four-handed, backhanded passes and left and right. So I right now have loaded my needle for a four-handed, right-handed pass. In strabismus surgery, many of us, including me, do both right-handed and left-handed passes. So there's different ways to do the scleral passes. So any questions about loading your needle? No. A very important basic concept too is never grab the needle at the sharp part of the needle. So once you've placed your patch and you're trying to pull it through, for strabismus surgery and any other surgery, you want to avoid re-grabbing the needle on the sharp tip. That will blunt your needle, which makes your scleral pass more difficult and more dangerous. And for other surgeries like corneal suturing, et cetera, it'll blunt your needle. So try just to get in the habit of never doing that. Okay. The two things I always emphasize is you want your tip up. And so you're making these little movements, making sure your tip is always up, and you want to have your needle flat. So you don't want to have your needle passing like this on an, hopefully you can see that, on an angle, because remember the needle is a side cutting needle. So if you're passing your needle on an angle, let's say a 45-degree angle, now when you advance through sclera, you'll be cutting through sclera posteriorly. You don't want that. So you always want to make sure that needle is nice and flat. Okay, I'll just demonstrate with my hand here in case you couldn't see the needle. So if this is the needle, here's the sclera. You want your needle to always be flat on sclera. You don't want it to be turned on its side as you advance. So you're thinking flat, you're thinking tip up. You dip in ever so slightly to get some purchase of that sclera, and then you advance and push through. So this is intended to be like a rectus muscle. So I'm going to grab, we're pretending this is the insertion of the muscle. I'm going to place a central, what I call a central security knot. It's a central knot. So I'm going full thickness here. Hopefully. I think that might be partial thickness. As deep as you can for that. Can you see my suture here?
Yeah.
So here I'm going to do just a single throw, and I'll keep this double armed. So you're going to do a loop here and pull it all the way through. Okay, so that's the first part of my knot. Just a single throw, meaning just looping it over your needle driver once. And then you're going to grab the other end. So you're doing a square knot. So here you can just do a single. So I see you going, if you look at my screen, you just need to do the loop once and pull it through. I saw you going 1, 2. That's if you really want to secure it at the end. Just do 2 single throws. Good. Okay. How are you doing, Wei Yan?
Yeah, trying.
I think the foam that you have it's almost more like a sponge, so it makes it a little trickier.
Okay.
But it's the same concept. So practicing, your forehand, and really it's this motion. If you see my wrist, you're really twisting your wrist when you do the backhanded. So you're, passing it in order to make sure the needle tip is safe.
I've got the 8 here.
Let me just see here. Okay. Okay, great. So now you want to, with your needle holder, you want to make a twist of that loop. Do you have a twist there already?
There's a twist, yeah, right here.
So then put your needle driver through that twist and then grab the suture and pull it through to make the knot.
So am I putting it in the sort of the inside or the outside of the twist? Does that make sense? So in the inner loop or the outer?
I'll demonstrate it again because it's hard for me to see the white suture on the white foam there. I haven't heard anything. So go ahead and do the locking bite on the other side. And I'm going to do the same. Oh, I'm halfway through already. So this one will be forehand. So again, full thickness. Pulling it through, and then I've created my loop. And I pull the suture through. And you can see that loop there. So that's going to be the twist that creates the locking bite. Locking meaning it doesn't unravel. Yeah, and push it through. That's good.
Okay, and then that's the...
And with the loop, make sure you make a twist. Yeah, it looks twisted there. Good.
There we go.
Okay. If you have another, so I grabbed the suture. I'm going to do 1, 2. So I've passed, there's 2 loops.
Yeah.
See that? So 1, 2, and then grab, I know you only have the one suture, but you're going to grab the other end. Looking at my camera, hopefully you can see that. And it's tied down. So that's the first throw. So hopefully you can see that.
Yeah.
Okay, so it's a double. And the reason we do the double pass is so that it doesn't unravel and fall back. See, it's still falling back a little bit. Sometimes what I do in the OR is I'll have the assistant grab that so it doesn't fall back. So you've got your double throw there. And then you'll grab the other suture and do single. And then I like to do 3 singles. So 1 more. Okay, so now our muscle is secured to the sclera. There's the 2 scleral passes are not, and then you're going to cut the suture at the end.
I really enjoyed it because I'm very junior training. I'm only in ST2 right now, and I've had 0 experience in terms of Strab and pediatric side of things. So I found it really helpful actually to have someone go through the foundation and the actual basics of each of the steps and the procedure, because I think if it was any more complex than that, I would struggle to maybe keep up as much as I would have.
And I think this is a really amazing learning experience. So I'm only a first year resident, and I really know nothing about strabismus surgery. But I think this workshop is really enlightening introductory course, or learning opportunity for me, and it made me more interested to know more about strabismus surgery.
So that looked like great fun, Uni.
It was so much fun. You know, this is the first time we've done something like this. Of course, like you've all said, we've taught before. And I'm someone who really, really likes to be prepared, as many of you know, and like to make fun of me for. So I just didn't know how this would happen. And I would say it went very smoothly. And although there are, others in this group have mentioned some of the challenges, overall, I thought it went great. And I was really happy, especially because, as they've said, the trainees, some of them have never really held a needle holder before, loaded a needle, and that was pretty obvious. It's an efficient way to get trainees up to speed. And Rita mentioned really being able to use your words and learn how to verbalize some of the things you might say. Oh no, turn your wrist like this, grabbing some. Oh no, why is your arm up like that? Why are you doing, you have to learn how to take all the things how, you usually do in person and just be able to explain it in words. I believe it was Rita, or I think it was Rita again. You made so many good comments about being not rushing and having a good attitude and being prepared. And I would echo those comments. And to quote my mentor, Dr. Wright, he'd say the best way to go fast is go slow. He's a fast surgeon, but he's never rushed. And I hear his voice. My students hear my voice, which is probably his voice. And it's one big circle of learning. So I thought it went really well. There's just little things we've learned. I think I mentioned in the video, having contrast of the sutures and the model. Those are easy things to overcome. I love that we had, the 5 of us from all around the world, different times of the day, and students from all around the world, different levels, even within junior. David, your trainee isn't even a medical student yet. So it was fun, and I look forward to making it even better from everyone's feedback.
Have you practiced
We're just saying, Rita, with the laptop facing Tracy, you get a really nice feed. She was leaning in and watching you, and her hands were going like this. It's really nice to have that feed. And what you can have, as you know, is to have a second camera away from the model eye, looking at their hands to see how their hand position is. We've done that for some anterior segment surgery. But Tracy was and others were so enthusiastic. She was looking right forward to see what you were doing, and then mimicking. She's almost like that person, a gymnast or somebody on the high board about to do a dive. They're going through all their muscle memory. I
didn't notice that as I was teaching. I was so focused on trying to get my message across. So one thing I think is wonderful about this modality, and between us, and we're going to be researching that, is looking back at the videos. I find it very painful to watch myself on videos. Actually, I dislike it immensely, but I was learning. I'm like, oh, that's how I got to work on that. And I think for the trainees also being able to go back to their videos and say, oh, okay. So not only going back to your, the simulated ocular surgery videos or other higher level instructional videos, but your own video and thinking, how can I improve is a big part of being prepared.
Have you practiced
that's a great point.
model before the session?
I had not practiced really on this model. So it was pretty new for me. So it was good. The trainees and I were similarly being introduced to the model. It was easy to use. I mean, I thought it was a good tool.
Yining, do you think it matters when you're training someone from a different program? In other words, they don't feel like they have to impress you. They're not going to see you again. You're not grading them. Is it a little more relaxed, or is it feel the same whether it's your resident or somebody else's?
It's probably more relaxed. I don't think I'm too intimidating in my own program, but maybe no. I mean, definitely compared to being in the OR, it's way more relaxed. And then especially because these are new learners and they don't really have other learned skills, so they're really fresh. It's fun. It's like the beginner's mind, right?
Yes.
So I'm sure it's less stressful. It could be more stressful for the trainee because they don't know us and they haven't developed that connection. I didn't feel that at all. I mean, I didn't get that sense from the trainees of it being any worse, or I think they were all.
Tracy also said that she thought that learning the foundational principles was so important. I wonder if we're not helping everybody from oculoplastics to cataract surgeons by working on foundational principles of surgery and just talking about this model.
Well, as we've talked before in other webinars, a lot of the ophthalmology med students or residents, they're learning those basics from us because ours is often the first surgery. So it'd be even better before they get into the STRAB session I agree with you, learning those basics, which there's going to be huge variation. So getting everyone up to a certain level, it would be good.
In the interest of time, we're going to move on to Ramesh's workshop. So I'm just going to screen share again.
We can.
So first, to secure the muscle, I would take a central bite in the middle third.
Yeah. Okay, this step, I just wanted to you to see, when you again started doing it, you were vertically down.
Okay.
Again, here also you need to be. Like by default, we will be like that. Here also what you need is, this is a partial thickness, right? The first part what you're going to pass is a partial thickness. So be flat as much as possible.
Okay, okay.
Yes, that's perfect. Yeah, here, this is very important. You are already keeping the last 2/3 of the needle visible to you so that you can grab that part from that needle. That's what you're trying to do.
Yeah.
Good.
And then I'll do the same again.
Yeah.
So another partial thickness in the middle third.
Yeah.
So.
Yeah. This time you're flat. This is the way it should be done. Perfect. Again, you need to gauge that. Where are you holding that? So 2/3 of the needle, if it comes out, re-grabbing the needle is easy for you.
Yeah.
Otherwise, you will have to use the other hand once again. Yeah.
Yeah.
So
And then
central knot, you have it already. That's great.
Yeah.
Yeah. Okay.
I held the tip by mistake.
Yes.
Okay.
So as much as possible, tip should not be held, because this should become this is the way I think even our fellows start or the residents start. You keep on doing on this model exactly all these times, maybe 50 times or 30 times or 40 times, thinking about all these steps, then you will never do this mistake on the live patient. This is extremely important. Flat, hold like a pen, the needle. Your wrist should really be flat. Otherwise, you will have this mild tremor. It can be possible because you need that rest for that. And never pass it vertically down. Flat, flat, flat. See this? I can pass it like this, or I can keep it all the time like this. This is what you should. For a cataract surgery, if I have to suture a corneal, a scleral bone, I'll have to go that. Here, everything has to be like this. So if you can do that, that's the biggest advantage. And it has to be, you can always say that this is the model eye, but these principles you will never, when you're doing surgeries, these things will come around your ears, do that. Don't touch the needle. So the next one should be full thickness. For that full thickness, you need to use your second instrument. The forceps, what you have on the other side, should lift the edge of the muscle. Lift it, yeah.
This way.
Yeah. Again, you should be
and
flat.
full thickness of this.
Full thickness, but you are trying to be vertical here. You should not be so vertical. You should again try to be flat. Not as flat as before, because you need to pass full thickness.
Okay. So how do we go flat with, as in the tip is this way, right? So you have to engage.
Correct.
It.
So you are.
Okay, so can you press the muscle down?
Yes. See that? You are using the left one to make it almost vertical. Yeah.
So I raise the muscle, I press this down.
Go. Yes, it has come. You don't have to be really vertical, right? You could still be flat because you are using the second muscle. And this is the full thickness. This time, when you come out, you have not locked the muscle. You need to lock it. How do you lock it? You have to go through one of the edge, the knot, the loop of that. It has to be locked. That is why it is a locking bite. Stops working. Yeah, it's working. I can see you. 2/3 of the needle is almost out. Yeah. This step, Marushka, make sure that you don't hold the tip. Now, that is the loop.
It's quite a big loop.
Yeah. Yeah. What Meera did is, she came out and then looped it. What I do is, when it comes out, I take it like this, and then immediately when it's out, I go through the loop. This loop, what is that? There are several ways of doing it, but if you do that way, you will save some time. And your sutures cannot entangle. Otherwise, it can entangle.
Marushka, I think you're next.
Yes, I was with Dr. Ramesh, and he, learning from an amazing person who's so accomplished like him, was really good that he came down to my level. And, like taught me the basics, because I think when we practice that is when you can really become better at the actual surgery, when you have your basics right. And I'm really happy that now I know my basics and I know what to practice to get better.
I just want to say that the group sizes, I think, really was ideal, because I think if it's sort of any bigger than sort of two students and a trainer, I think you sort of almost feel not confident to speak up, or you don't want to, ask questions that might delay other people. Whereas I think when it's quite a small group, it really it just is very familiar and easy to ask questions and also get personalized feedback and feel like you have time to do what you're doing. So I learned a lot from watching Mariuszka, first of all, and secondly, I think the group sizes were absolutely perfect. So thank you.
Ramesh, another great session, and some great points made by the trainees there about the size of the groups and watching other people. So it's not time wasted when they're watching one of their colleagues practicing.
Yeah, I thought that that was a very good thing, watching the other colleagues. That's what happens in the fellows group or the residents group. When the others do, and if they can watch that video, they learn a lot. I saw that there are two advantages, John, with this. One is you are relaxed, as David asked, Ening. You are working in a different group, and you are at home, and even the fellows are at home. They are not next to you. And the second advantage, I thought, I showed a lot of hand movements. You can really show that on the Zoom. The second important point is you can record. Both we can record and they can record without any additional cost. That makes learning much better. When as Yining said, when I look at my videos, I could have zoomed up some of the steps. I can retrospectively think now, I could have done that. I could have done that. Both, even the mentors and the mentee, the trainers or trainee will think the same. There is an easy and the cheapest way is to record, and they can go back. There is a lot to learn after you do this practice surgery. That's my comment. There are any questions I can answer or any comments?
How do you think
John,
sorry, you go ahead.
Go ahead, Rita. I'd rather hear from you than me.
How do you think this will change for your students? I've heard one of them was really struggling in the beginning. How do you think this will change? Will they practice at home?
Yeah, I think there are three things are going to happen with this kind of training. Number one, they get familiar with surgery. They get familiar with your steps, and they know what are the steps 1, 2, 3, 4, 5, 6, 7, 10, or 9, 10, whatever it is. And they will learn the instrument which are required. The improvement which I'm already thinking is we need to set up a similar kind of orientation. How do you sit in the OR or stand just opposite the muscle? These are the finer things we need to bring as we go forward. So this makes you prepared. They're not stumbling like Rita. One of your trainees is passing the suture on the same side. These things I think is precious for a surgeon who is beginning. I think this way, I think it's great. And the most important, if you look at the world, there are different people with different resources. Here, what you need is an internet connection, plus I would say cumulative of $10 to set up this. This is incredible. If I was a trainee, now, if I have, training from David, that's fantastic. I'm a resident, I'm getting trained from David or John. It's really, really precious for me. So that's the way I would think about this.
Yeah. I think one of the phrases that Will Dean uses, it democratizes surgical training. It's open access to everybody. I'm mindful of the fact we've got 10 minutes to go, so I'll just play the very last video here, and then we'll have time for comments at the end, so we can screen share. Again, no, that's too vertical, Derek. Okay, so that if you do that in real life, you're going to go through the sclera. So if you watch my needle again, if I just try and, just trying to make this full screen because I'll just try and show you the difference in angulation. I'm just going to hold a different model eye here at an angle. So you're approaching it like this, and you're relying on you just going at the right depth. Just push down vertically. So on the sclera, just push down, go in a straight line, then roll your finger and thumb, and you'll get the right depth. So at no point am I going like this. Okay. It's flat, pushing it down, and then rolling it. Okay.
So here is Derek, who had done no previous strabismus surgery, making 2 safe scleral passes at the end of our session. Bearing in mind his first passes, the needle was pointing directly down into the globe. He's now making a lovely long safe scleral pass, the backhand, and now he's doing a forehand pass, again achieving safe entry of the needle into the sclera and making a nice long pass with no danger of that needle tip passing through the sclera into the globe. He's got complete control of the needle all the way along the pass, so a big improvement. And Hetty doing a similar exercise, making a backhand pass parallel to the limbus. Again, nice depth, nice control. And she's just working out in her own mind just how to hold the needle holders, ready to regrasp the needle, so ready for the next pass, and she does it successfully.
So push down flat, engage, and then it's this twisting your wrist round like this to go and pick it up. You can have it almost the whole way through. It'll just sit there and then grab and come through. You see that, Derek?
Yeah. This is a clip of Derek undertaking continuous suture placement in a rectus muscle at the end of our wet lab. And the only instruction I gave him during this was just when I told him to pull this suture through, so it was halfway along the continuous suture. He has had no other instruction during the course of this suturing exercise. So he's placed 2 nice sutures through the middle third of the muscle. Being hypercritical here, he hasn't quite come out partial thickness, but a nice safe pass. He's regrasping the needle really nicely now, ready for his next pass. Full thickness pass through the edge of the muscle. He's now just holding the suture slightly long, but realizes this because he can't wrap around the needle. He shortens his grip without any instruction from me. Wraps it underneath once, twice, to create a locking knot. Pulls it through and secures it at the edge of the muscle. Now he's going to be doing his reverse mounted pass through the muscle. Again, confidently holding the needle at the correct place. Placing that suture, again not quite partial thickness but not bad, through the outer third of the muscle. Twisting his wrist round nicely, ready for making the next pass. Just snags here underneath his matchstick, but again he deals with it very nicely. Pulling it through. And again, final pass, full thickness. And he just lets go of the needle here, which wouldn't do in real life, but he's holding the suture at a reasonable length. Wraps it safely around the shaft of the needle, not around the tip of the needle. Pulls it through and secures it. And for a chap who's never done any strabismus surgery, I thought that was excellent.
And Dr. Ferris was your instructor?
Yes.
So I'm sure that you have a lot of feedback to help him get better. And I'm obviously having fun, but what would you say were the best parts, and what were the things that we really could do better?
The best parts for me was the interactiveness. He could make during the scleral passes and arm holding and re-grabbing my instruments. He could pick that up. Perhaps what I think could have been improved from our side is perhaps I could have just my model kept moving. So perhaps in future there could be just a note saying to stabilize the model before. And sometimes the image kept jumping in between the participants, but it didn't really cause that much of an issue for me. I thoroughly enjoyed the session. I learned a lot, and I could see my skill improving. So overall, great feedback, very minimal. I thought that it would need improvement.
Thanks so much for organizing this session. I was in Mr. Ferris' group just now. I think I completely echo with Hetty that Mr. Ferris was so patient, and was directing us every step of the way. And initially, for example, I was holding the needle wrong, and I was almost going perpendicular to the sclera. So probably a few eyes were damaged by me along the way. But so I could learn how to re-grab the needle and pass through the sclera safely. So I think I like the close supervision. I think everyone said that. I really actually enjoyed this session.
So the question I have for those people watching, especially the trainers, would you want Derek in your OR doing a procedure tomorrow? And for a boy who had done no strabismus surgery at all before the start of that session, that unedited clip, there's no editing, went on there, how fluent his movements were, how accurate things were, the knot tying, you're happy to have him start off and do a case with you. And that's what we're trying to achieve. You're trying to get that level of competence, as Ed said at the video right at the start, competence before you enter the OR. And it's very straightforward as trainers. You just say to your trainees, unless you can demonstrate to me you're as smooth as Derek was there before you operate, then you get no surgery. It's over to you. There's the simple model. There's the kit. There are the videos. Practice, practice, practice. And very soon your skin levels rise. It's great for patients. It's good for our coronary arteries as trainers. And it's good for the trainees, because Rebecca Jones, who made those lovely videos at the start, my second year trainee, she's done 40 strabismus procedures in her firm with me, including redos and inferior obliques. Why? Because she practiced, a huge amount by herself. And I think that's what we've demonstrated today, that practice really can make, if not perfect, competent.
Yeah, and John, I think that you and Yi-Ning have led us on this worldwide, that simulation is crucial. That, I mean, whether it's local or whether it's over the internet, there's such an advantage to having gone through this with such a simple model. So, I mean, it's been great. I have the answers to our mentee questions. Would everyone like to hear what we learned from our audience? So we have people from all around the world, really spread out, a little bit more in Asia than other parts, but everywhere in the world is represented. More women than men, as they self-identify. Age varied from as young as 21 to 30 to over 60 years of age, with in the middle, as you might expect, the larger part of the bell curve. This was interesting to me. We asked people what they do, and over 70% are already pediatric ophthalmology and strabismus fellowship trained. 6% are pursuing an ophthalmic residency, and 17% were pursuing a fellowship. So a lot of trainers wanted to see this. A lot of people still wanted to learn. We asked, have you seen any strabismus surgeries, live or recorded? And 100% said yes. And 80% said more than 10, but most of them said it was live, not recorded. And less than 20% said they saw recorded on YouTube or first a simulation. Most said they were familiar with the instruments, and about 80% said they had done surgery before, strabismus surgery, with about 70% saying they'd done more than 10, which makes sense since these are many strabismus trained, fellowship trained doctors. Are you familiar with any model eyes for strabismus surgery? Over half said no. So I think that we just changed one little corner of the world by making them familiar that this simulation is available even. And we probably, John and Yining, should mention what the other models are that are available at some point as well, because there's more than just the very simple model that we talked about. Almost 70% said they've never used a model eye, never did any simulation before. So that's the paradigm that we need to change. And then I'm going to share my screen to show this very last thing, because I think it's worthwhile seeing. And this was what was the best part of the webinar and discussion, besides all the other teachers and all the rest of it. So people seem to like us interacting and discussing. That's the feedback from our audience.
Fantastic. It just really leaves it for me. I'm just going to screen share for the last time. Yeah. Oops. Sorry, folks. Yeah. Really, just to thank Rita, David, Ramesh, and Yining for your amazing hard work over the last month putting this together. Particular thanks to Dara and Akila at WSPOS, the admin side, without whose help and expertise this wouldn't happen. And a special thanks really to all 10 trainees who took the initiative to sign up to this and put themselves on the line in a way. Hopefully you will have enjoyed watching those edited highlights of your session. And in June, we'll be running another webinar. We're going to focus more on intermediate skills and advanced surgical skills. So please look out for that from the WSPOS team. Hopefully, judging by the Menti questions, people have got a lot from this. Go out and practice. Buy the materials, 1 millimeter foam, ping pong ball, plasticine, stick the model down and get practicing. Because even more senior surgeons, we can always do with more practice. This is not just for trainees, it's for everyone. And hopefully that message came through loud and clear. So good evening, good afternoon, good morning to everyone. I hope you enjoy the rest of your Saturday, and we'll see you next time. Thank you.
Thank you, everybody. I like that, John. Go forth and practice. Bye, everyone.
Bye.